Hello everybody, my name is Brock. I'm one of the flight paramedics at North Star, and today we're just going to have a kind of like panel discussion on rapid responses, the deteriorating patient, and code blues. Just for you guys and for your brains, so you kind of know what we're seeing when we come in, and just to best prepare kind of for the eventuality that you do call a rapid response or a code blue.
My name's Day. I'm one of the flight paramedics with North Star.
My name's Natalie. I'm one of the flight nurses with North Star.
My name is Samantha. I am one of the flight nurses with North Star.
So bear with us as we try to do this with masks on and try to yell at the phone loud enough so you guys hear us. But to start us off, Sam's just going to start with some questions and kind of things that we were just thinking about as we were starting to prepare, like what would you guys want to know and how can we best help you guys for that type of event, because it is a scary event, especially if it's your patient and you get your nerves going and everything else as well. So you want to lead us off, Sam?
Yeah, so we'll start about deterioration in your patient. These are some things, kind of what trends will you see in your patient, and what is something to kind of be alert on when you start seeing these things in your patients. So first question here are, what are some patient trends that we may see in a deteriorating patient?
So from our perspective, nobody knows the patient like you should know the patient. This is maybe the first time we've ever seen them, so even starting as simple as their mental status. How are they acting normally, or how are they acting different than what they normally act like?
So that like acute mental status change, right? Because if we come in and the patient's super confused and you're like, well, I don't know, they're usually always confused, then it's a little bit less of a serious change for us, right? But if they were just chatting with you 2 minutes ago and now all of a sudden they can't put words together, that's a significant change, right? And that could be a significant problem, that a data point that everybody will need to know. So knowing your patient is going to be ideal, right? And other vital signs that we want to talk about are going to be things that you start to see right away. So like first signs of shock, Natalie.
So for vital signs changes, one of the first things you're going to look for is changes in your heart rate and how much oxygen they're needing. Are they needing more and more oxygen throughout their stay? Is their heart rate becoming progressively more tachycardic, or is it going lower? What's happening? So those are big things to pick up, because today, if suddenly you walk in and your patient has a heart rate of 130, well, were they like this yesterday? Has this been happening? Are they anxious? What's happening? So it's a good idea to look back and see what's going on. Another thing to keep in mind is when we see low blood pressures, this is usually a late sign. So we've missed some signs that have led to this low blood pressure. So it's always a good idea to kind of keep an eye on the rest of your vital signs and see where they're trending and what you should be concerned about.
And things that you can kind of assess quickly, right? Like you can palpate a pulse pretty quickly if they're not on telly or anything like that. And if they're all of a sudden tachycardic, then that's probably a problem, right? And you start picking and choosing these vital signs that are just additional data points, right? So you have that acute mental status change, and say your patient's confused and now they're super tachycardic. Now we're like double concerned, right? So you just kind of compound all of these changes in vital signs, and they should all just kind of compound your concern, right? And another thing I kind of want to chat about real quick is a respiratory rate, right? And it's kind of one of those things, at least in the ER, that you might just be like, 14, 16, and they look like they're breathing okay, so that's their respiratory rate. And anyone that says they counted every respiratory rate of a patient, they're probably lying to you. So be vigilant with that, especially on your sicker patients that you might be concerned about, because they might look like they're breathing okay, but they could have a respiratory rate of about 30. And that's going to be one of those vital signs that are going to pop up at the initial stage of becoming very sick, right? The tachypnea and tachycardia will always happen before more than likely will happen before your patient becomes critically hypotensive.
So on that note, if you're starting to see any of these signs and symptoms in your patient, you're concerned, you've paid your doctor, you haven't heard back from them, would probably be an appropriate time to bridge into a rapid response. So bridging off of that, when is an appropriate time to call a rapid response?
Anytime you need help. We don't want to put specific parameters on when to call a rapid response, and you should never feel worried about calling a rapid response. If you need help, you need help, and that's what you have to do. And we never want you guys to feel like you're being looked at or judged for calling a rapid response, because literally the worst/best case of a rapid response is you call one, everybody shows up, and actually the patient is fine and they cancel it and no big deal. I mean, that's the worst that can happen, and that's great. The worst, absolute worst can happen is not calling a rapid response, and then your patient progresses and gets even worse. So you should really never feel bad about calling a rapid response. If you need help for whatever reason, for a change in patient condition, call the rapid, just so you can get more hands.
And if anybody makes you feel bad for calling a rapid response, then they're wrong. Because the rapid is a feeling. It's not, I'm gonna wait until my patient is 160 beats per minute, but they're 155 right now. I guess I have to wait a little bit longer until they hit that brink, right? It's a feeling that you make, and anyone that gives you a hard time for it is they are wrong, not you for that.
Right. One of the main reasons we're here talking to you guys, talking to a phone actually, is because we want you to be comfortable calling a rapid response. It's a part of your job, and we want you to be comfortable in doing it and prepared to do it. We want you to know the things you should look for and when to call it, and what you should do once you have called it. But most of all, we want you to be comfortable in calling one.
Okay, so I am going to act as the primary nurse in this role of rapid responses. So what should I do after I call a rapid response? What is my main role?
So I think one of the big roles as the primary nurse is, first step is take a couple deep breaths, everything's gonna be okay. Because it's super nerve-wracking, especially when all these people come rushing into the room, your mind's going a million miles a minute. Take a couple of deep breaths, gather your thoughts, and your biggest role is to be the storyteller. So what the heck happened? You want to be the storyteller for that patient. What changed, why it changed, when did it change, what do they usually look like? So a good way to put it is just everybody, I know Trinity uses it, it's taught a lot in nursing school, is to use an S-bar. What's the situation? What's the background of this patient? What assessment findings did you find? And go ahead and just announce that to the team when they get there. Yeah, I think that's the big role of the primary nurse, is just to be the storyteller. If you can do anything, that's super helpful, because nobody knows this patient as well as you. Even if that's your first time having that patient, you're gonna be the one that knows them best currently.
And really, just to piggyback off that real quick, Natalie said something about just taking a second to think and to kind of get your thoughts together, right? And that's awesome. Like that's something that we practice even, in flight and even through everything else before like a serious procedure or anything like that. Take a second. Nobody's gonna, nothing crazy is gonna happen in the 5 seconds it takes you to collect your thoughts, put everything together, and deliver it elegantly. Than just kind of just word vomiting everything else and shooting that out. So just take a minute to breathe, because that's okay. Take 10. That's fine. Sorry, continue.
Are there any materials that should be in the room for the rapid response team?
So there are a few things that we would suggest bringing into the room. A glucometer and all of the things you need to check somebody's blood sugars are a really good idea. If they're there for something like shortness of breath, bringing extra oxygen supplies in, have somebody get a non-rebreather or a bag valve mask. Have your crash cart right outside the room.
You took all the ones that I was going to. We should have better prepared which equipment we were going to talk about.
And to spitball off that, one of the big thing is, so these things should be nearby, but at the same time, being the primary nurse, we don't want you to necessarily leave the room because, again, you know this patient the best. So those duties should be delegated to someone else. So if there's a CNA that responds or just another nurse who's not involved, simply ask them, can you get the glucometer? Can someone grab the cash cart and put it outside the room? Simple things like that. And that way you can stay with the patient and keep monitoring them or do any interventions that are needed in the meantime until the team arrived.
And, you know, so when you call these, you're going to get a whole bunch of people, right? And that's kind of what makes it nerve-wracking too. But that also makes space an issue, right? So generally clear things up a little bit. If you have, you know, a whole lot of stuff everywhere and we can't really get people in, maybe ask, you know, somebody else that's like Natalie was saying, as the primary nurse, you want to stay in there, but somebody else could probably help you clear stuff out and prepare for the sheer amount of people that you're going to get to come help you out.
Right, so if there's extra chairs in the room that don't need to be in there, the bedside table that doesn't need to be in there, maybe there's a commode in there that can be moved out just to clear up some space for the people that are going to be in there.
Yep.
And then if you have the ability to bring in a computer, that would be beneficial too, because one of the first things that somebody's going to ask are what are their lab values? Have they had their labs drawn recently? And having the ability to look those up in a timely manner would be helpful.
Yep. And I think it's totally understandable. We get that. We keep saying that you guys know this patient best, but you still may have just come on shift and only had the patient for 10 minutes. So you really might not know them a ton, and this might be your first time laying eyes on them. And so when the rapid response team comes, a lot of times there's like tons of people asking questions. They want to know what this patient looked like yesterday, what were they admitted for, all these questions. And it's okay, nobody expects you to have every single answer, and it's okay to not know, but you have to have the resources to find out. So your response might be somebody asking you what the patient was admitted for yesterday. You might say, I'm not sure, but let me check, and delegate. You know, you might ask your charge nurse, check in the computer, whatever the reason is, but try to find out. It can be frustrating sometimes when people are asking questions and nobody knows the answer, but nobody's trying to find the answer.
So just to bridge on primary nurse role there, another big thing is also knowing their code status. A lot of times we walk in the room and it's a respiratory issue and they're on 100% on BiPAP, and our first question is always, well, are they a full code? Should we get ready to intubate? So big rules as a primary nurse: know your code status, don't leave the room until the rapid has ended, and just take a deep breath and know that we're there to help you. We're not here to make your job harder or anything. We're here to help you and figure out what's going on with the patient.
Yep. And totally okay. You might not know the code status off the top of your head. You probably have 5 other patients, but it's okay to be like, I have to find out. Let me check the computer. If not, we're going to call the doc and figure it out.
So from there, we're going to bridge over to code blues now. Biggest question here now is, when do I call a code?
If you feel like you should call a code, you should probably call a code. I think that is the easiest way to think about it. If you try to palpate a pulse, right, 10 seconds, you don't feel anything, or you don't think you feel anything, or I don't know, I might, just go ahead and call it, especially if you couple that data point with your patient being unresponsive, being apneic as well, right? Because if they're apneic but they have a pulse, you should still call a code, right? I mean, that's not going to sustain them for very long.
So what are the big things, like list them? What things do you call a code blue for? Like, what are the actual things? Just list them off.
For calling a code blue?
Yeah, like what would prompt you to call a code blue?
If they're pulseless.
Okay, so no pulse.
Mm-hmm. If they're apneic, if they're not breathing at all.
Okay.
If they're unresponsive and you're not sure whether or not you can feel a pulse, or you're not sure whether they're breathing.
Or if they have any sort of like agonal respirations.
True.
Like we call it kind of guppy breathing. They're breathing but not effectively.
That's a phenomenal point. They might not have that true apnea look to them, but they're definitely not moving enough air to sustain life. Is a good way to try to remember that part.
And like they said, if you're questioning it, you're better off just calling it. Because again, best/worst case, the entire code team comes and your patient's actually not a code blue, well, great. If they need help, there's all these people there that can intervene and help, or they're just actually totally fine and maybe they just fainted. But either way, there's people there to help, and best case for the patient is they're actually not a code blue and everybody gets to leave.
And if you are questioning, you're confident that you can't feel a pulse, and you start compressions, that patient will tell you for sure if they're alive or not. If you start compressions, they're gonna wake right up. No,
Right.
thank you. So don't feel like it's a right or wrong answer when calling a code. And then again, room setup for code blues. What are some things that I should have in the room?
So easily the code cart, right? We want a code cart, and to kind of go into the code cart discussion a little bit, have it be properly stocked too, right? Because as North Star, we'll come up with an innovation bag, but that's it. We can control the airway with that, but make sure that it has suction. Anytime that we intubate, we usually intubate with suction, leading with suction. So make sure that that's set up and that you know how to set it up too, because you might, it's not something you might set up all the time. So making sure that you're competent enough with setting up the suction as well.
Right.
And there's small things you can do before the code team arrives. Again, we don't want you to leave the patient, but if the crash cart arrives, you can start hooking that patient up, putting the patches on, and just turning on your life pack, because it'll automatically turn into an AED and tell you what to do. And you might even get to defibrillate your patient before the code team even gets there, and your patient is awake by the time they get there.
Right.
So it's small things that you can do. It's okay to put those patches on and turn on the life pack. Nothing's going to happen. It'll tell you what to do.
Put the backboard, the compression backboard underneath the patient. So that's done by the time everybody gets there. If you need to wait until they get there for the help, then that's acceptable too.
Yeah.
But certainly get on the chest right away, if you don't feel a pulse, or have somebody get on the chest right away.
If you're in there by yourself, you don't feel a pulse, pull that code light and start compressions right away. Everybody else on your floor will help you until the code team gets there.
Right.
And similar to the rapid response, once the code team arrives, again, your big role is going to be the storyteller. What happened to this patient? When did they come in? What were they doing before this happened? Again, use your S-bar. If you need to use your sheet, I know lots of people carry around what we call like brains. It's totally fine to pull out your sheet and read off what's your sheet so that everybody knows what's going on with this patient and they can get a better picture.
So, are we done with that?
Yeah.
Okay, so really just in conclusion here, and just kind of points to highlight is if you're primary nurse, stick around, right? It can be kind of stressful when everyone comes in that you almost like want to like sneak to the corner and like hide a little bit. But we rely on you so much for you to tell us kind of what's going on, right? You are the storyteller, like they were saying, and this is. Day and I were talking about it earlier. This is kind of like a 911 call, right? You're phoning for help, but then you're also kind of giving a little bit of a report with it. So following that S-bar and really just going with your feeling, right? If you feel like you have to call this, call it. It's better safe than sorry, and anybody that gives you a hard time for it, they're not worth it.
Yep.
They're not worth it. Your patient is worth it. So give your patient that shot and trust your instincts. You go through a lot of school to know, to know medicine, to know what's going on with your patient. So be best prepared for that by knowing the trending vital signs and keeping an eye on your patient, not just, checking in on them at the bare minimum that you can. But, just don't feel bad about calling them is really kind of what I have to say.
A rapid response is the quickest way to get attention. We talked about this before we started filming, but often in the ER, sometimes we'll transport our own patients to CT if they need nurse accompaniment or the CT's busy or whatever else. And I always have the thought in my brain, I'm by myself with a patient. If something happens, I'm going to call a rapid response and CAT scan just so I can get more help because I'm only one person. So anytime you need help, you should never feel bad about calling the rapid.
Right. We want you to be comfortable with it. We want you to understand that it's acceptable to need some extra help. and that there are people here that will come quickly to help you.
And easier said than done, right? We can all say, feel comfortable doing it, and just call it when you need it. But when the time comes, it's hard, and we get that. I think for the nurses too, whether they worked on the floor or not, they feel that too, that stress of calling one. And even when I started as a flight paramedic here, and I was on a PEDS floor for a sick patient, and I felt like I needed to call rapid, and nobody else was thinking that we should call rapid. And so I was like, well, shoot, and so I started to feel that stress of, well, I don't want to be wrong. I don't want people to think that I'm just calling them up here and wasting everybody's time. It's okay to feel like that, but I really just want to encourage you guys to, push past that feeling, and when you feel that need to call it, just send it.
It's definitely going to be an uncomfortable feeling. My first rapid response as a baby nurse was the scariest moment of my life, and it's going to suck for sure. I mean, there's still times in the ICU that I'm in a patient's room and I'm screaming out the door for help, so don't feel like it's not going to happen to you, because
Yeah, and I think from each experience you grow, right? After your first rapid response, you probably learned, shoot, next time, like maybe I could do these things so it would go better, because they're going to happen whether we like it or not. So I mean, you can take each opportunity and just grow from it. You're not going to be perfect, you're not going to do everything right, but if you can take the opportunity, grow from it, ask questions, debrief afterwards, so that we can all get better and do it better as a team and work together, I guess.
And I think one thing we do as nurses a lot too is, what did I do that made my patient be this way? Like, why did my patient code? Why did my patient stop breathing? We put a lot of blame on ourselves, and it's really nothing that we did. Just try and remember that when your patient's deteriorating, it wasn't your nursing care, it was just their prognosis of when they came into the hospital.
Yep. Solid point.
Now, a lot of what we said is relevant to just codes and rapid responses in general. But as you guys know, COVID's a big deal too, and things change with COVID positive patients as far as code policy and rapid response policy. So if you do find yourself working on the 5th floor or working in, with COVID positive patients, review those policies too, because it's the same thing. If you feel it and you need to call it, you call it. That part doesn't change. It's just some of the preparation that does, and really the people that are going to be allowed in there and everything like that. And that's not really, we don't really have a whole lot of time to cover that part of the video, but if you do find yourself on those floors, definitely review those policies, and reach out to your management if you have any questions, or reach out to any one of us, because that is becoming a big part of our world. So yes. Do we have anything else?
I was gonna say, just a thought, we forgot to mention this, but to remember to be familiar with the equipment you're responsible for. So like the crash cart and the life pack. So obviously as a new nurse, you've probably never used them. So to put hands on it and know how they work, and if your educator or manager doesn't do that, you can always feel free to ask one of us. I'm sure we'd be more than happy to show you what goes where and how the life pack works and everything. So never be afraid to ask for help. It's better to be prepared than to be unprepared, right? You'd rather be over prepared and never have to use it than be underprepared and then have to use it and have no idea how.
Right.
Don't let your first code be the first time you're touching your crash cart.
Yes.
Yes. It's similar stuff we do. We call it high acuity, low frequency procedures, where things that we do sometimes, we've never performed it in our career, but there'll be a time where we might have to, and we'll have to be very good at it. And that's the same for your guys' world too. Sam was saying, don't let the first time you touch the code cart be when you're having a code, because we never rise to the occasion. We always fall to our level of training. So just remember that as you start your job and start working around. So
as flight, we always kind of say, prepare for the worst, but hope for the best.
Sure.
That's kind of what we do, and I think it kind of applies everywhere. If you prepare for the worst, it's harder to be surprised.
Right.
Well, cool. Thanks for joining us. I know it's a little bit different with a pre-recorded lecture. I feel like it might have been a little bit better to do it like this. I'm not really sure. So if you guys enjoyed it, that's awesome. Let us know. Maybe we'll do a little bit more of these. Because it's kind of fun. I think we all like talking about things and discussing things. But yeah, enjoy the rest of your day.
Okay.
Thanks for listening.
Thanks for listening. So next couple videos are going to be a mock rapid response. So we'll have 2 of them, one suboptimal and then one that's pretty good. So during these, think about things that you might have been better prepared for, things that you should have thought of, or things that you would have done differently. And throughout these videos too, I'm going to be playing the family member that's there. And I think that this is a really important part to consider, is that in these rapids and in these codes, families might be in the room, right? So keep your demeanor and keep your words in check. A lot of things that we might say as healthcare professionals, say to each other are not always appropriate to say with family members present. And I'm an offender like everybody else, but it's something we have to consider and something we really do have to keep in check when family is present. So hope you enjoy these next couple videos and hope they can kind of give you a little bit of a brain exercise throughout them.
Knock knock. Just coming in to check on her.
Yeah, I feel like something's just a little bit off with her today. Sam?
Yeah, I don't know, maybe I'll just call her Appa just to see what happens.
Sam?
5222. Hi, can I get a rapid response in room 720? Thanks. Well, I guess I'll just wait now for the rapid response team to show up.
Okay, she just feels really weird right now. She's not
Okay, I
Sam.
think.
Sam, this is just a lot different for her.
Hi, I'm Day with North Star.
Oh.
What's going on?
Thank God you're here. I'm
Okay.
glad you came. Thanks.
Okay. Well, hi. Hi, hello. Can you hear me?
So she's just being weird. I don't know what's going on with her. I just got here. I was coming from out of town. I've only been here for about 10 minutes.
Okay. Do you know what she's in the hospital for?
Something. I think she had a surgery.
Okay.
I was just kind of clearing up and switching her mom out for this.
Okay. What kind of medical conditions does she have?
I don't know. I don't know. Where's the nurse at? Do you know? Maybe we can go talk to her somewhere.
Oh, did you
I don't
meet
know.
me?
Yeah. What is she here for?
Gosh, I can't remember if it was her or my other patient.
Sam,
Maybe
guys, she's really just, there's something off with her today.
Is she diabetic?
I don't know.
All right. Well, can we check her blood sugar?
Yeah.
Yeah. Go grab a glucometer. We'll check her blood sugar. Sam, can you hear me? Squeeze my hand if you can hear me. Not really much response. Maybe a little bit. I wonder how long she's been like this.
Yeah, I don't know. I just got here about 10 minutes ago.
Okay.
Yeah, so here's the glucometer.
Okay.
So thanks.
Thanks. Okay. Thank you. We'll check your blood sugar here. Big poke in your finger.
Is her blood sugar good? What's
36. Okay.
Sorry, I was just checking on all my other patients because she's like my least worry, so.
Okay. Well, her blood sugar's
her
36.
your least worrisome?
Oh.
Does she have a
She
good
doesn't
IV?
look very good.
I haven't checked it.
Okay. Well. Will you grab an IV tray?
Sure.
Thank you. Okay, I will go ahead and start an IV and give her some IV dextrose.
Yeah, I think that's a good idea.
Okay.
Knock knock. Hey there, just coming in to check on ya. Sam? Has she been like this?
No,
or?
this is, I don't know. I just got here about 10 minutes ago.
It's really odd.
She
This
hasn't been
morning
doing
she
too
was
well.
talking to me and everything. Sam? I think I'm just going to go ahead and call a rapid response here. 5222.
Okay.
Hi, can I get a rapid response to room 720? right. So, Courtney, could you maybe put the crash cart outside the room and grab me a glucometer, please? Thanks. So just so you know, there's going to be a lot of people that come into the room just so we can get some more help and kind of see what's going on.
Okay.
Okay?
All right. Okay.
Sam?
Sam, I'm a little concerned for her.
Yeah, me too.
Hi, my name's Dave with North Star.
Hi.
What's going on today?
Let me get my sheet out here real quick. So this is Sam. She's a 20-year-old female. I just took over her care this morning, but she was admitted yesterday for cholecystitis, and I think she's supposed to have her gallbladder out at about 5 tonight.
Okay.
I rounded on her this morning, and she was fine. She was talking to me and very chatty. And then I just came in to round on her again, and now she just is kind of like decreased. She just kind of only groaned when I tried to wake her up.
Okay.
Yeah.
Is she diabetic?
Yeah, actually, she has a history of type 1 diabetes, and I checked her blood sugar this morning at 7 o'clock, and it was 85, so it was normal, so I wasn't too worried.
Will you check it again right now?
Yeah. Oh,
Okay.
there, Courtney brought the glucometer. This is great.
Sam, can you hear me? Sam?
Okay.
She's just really acting off. I don't know what's going on with her.
Okay.
So here, I guess we'll go ahead and check her blood sugar. I'm gonna poke your finger, Sam.
I'm gonna check and see if she has a good IV.
All right. And you know what? She has been, I guess, in PO for this surgery since about 7.
Okay.
Yeah. So.
Okay. Did you check it or?
Yeah, I did.
Okay.
Yeah.
What's her blood sugar now?
36.
36. Okay.
Shoot.
Okay. Well, she has a good IV. We go ahead and grab some IV dextrose and
Yes.
500 ml bag of saline.
Yes.
Thank you. All right, Sam. We'll get you feeling better in a minute here. Get your blood sugar up.
All right. I have the glucose, so we'll go ahead and give that.
Okay. We'll hook up the fluids. Push the glucose.
Perfect.
Hi.
And that's all that we have for you guys. So thanks for watching. This is super weird that we're doing like a pre-recorded kind of thing to it, but I actually think it is almost going to better serve you guys for this. So take what you can from this and, you know, rewatch it if you want to. And just remember that calling a rapid, calling code, it is scary. You know, like we have all done it at one point. We truly have. And the first time we've done it, it feels scary, right? So be prepared for them. Know what you need to have for it. And, or, you know, if you don't know where you can get the resources to find that answer, like Natalie was saying earlier. So thanks again for watching and have a great rest of your residency. And feel free to reach out to us anytime for questions or anything like that. You can get my email from Kelly if you have any questions on these rapid responses or codes or whatever, especially on these COVID responses, because they are different, right? Just a little bit different. So hope you guys enjoyed watching us kind of struggle through this for a little bit, but thanks.